हेलो एवरीवन, वेलकम टू टी टॉक्स, जहां हम हमारे ट्रांसजेंडर ट्रांसफ्रेंडली स्पेशलिस्ट के साथ मिलके ये जो ट्रांजिशन की पहेली है उसे सुलझाने की कोशिश करते हैं। आज हमारे साथ है डॉक्टर देबमल्या सान्याल, कंसल्टेंट एंडोक्राइनोलॉजिस्ट। वेलकम डॉक्टर।
Thank you.
या एंड कैन यू प्लीज क्या आप अपने आप को इंट्रोड्यूस कर सकते हैं? कैन यू प्लीज, आर यू कंफर्टेबल इन इंग्लिश और हिंदी?
Yeah, English.
ओके।
So, I'm Professor Dr. Debamalya Sanyal from Calcutta, endocrinologist, attached to some private hospitals in Calcutta as well, and dealing with general endocrine as well as with transgender. In practice from 2007, and have been seeing treating gender dysphoria and gender identity disorders for the last 13 years, 12, 13 years almost now.
That's great. So if someone wants to consult you, do they have to come to Kolkata, or can do you do any form of online consultation? And how does one make the initial contact with you?
Yeah, you can see I have my number out there. Also, we have I do online consultation as well, and if they want to do that, they can give the call, and then one can I can direct them how to go for the online consultation.
That's great. And how did you start treating transgender people? Because it's such a super specialty, and not every endocrinologist are treating transgender people. How did you get into treating transgender
Yeah,
people?
actually, when I started treating transgender, actually, at least in eastern part of India and in Calcutta, there was only one other person who was treating transgender, taking up transgender cases. So one is it was because there was so much gap with regards to the treatment and people wanting treatment where they were not getting adequate facilities as well. So that is something which actually basically inspired me to go for that. Second is with the fact that then subsequently I was involved in one of the first guidelines which came up from India and especially from eastern part of India. And I was involved with this whole group where we had from different specialities as well as from the community and lawyers as well, where we had developed the first one of the first guidelines of its kind in with regards to transgender care. So these and subsequently we have been developing guidelines, publishing papers as well, and having a lot of interactions and treatment also. So gradually, one is with regards to addressing the deficit and also subsequently association with regards to the development of guidelines as well as treatment protocols.
That's great. Now we have collected a lot of questions from the community, so we will go through them one by one. So one question we have received is, uh, do I have to stop my HRT before surgery? And if yes, how long before HRT, before surgery? And why do I have to do that?
Well, it depends on the type of surgery and also it depends on the hormone replacement therapy. For male to female, if you are on estrogen, especially oral estrogens, and if it is a bottom surgery where you are immobilized, that's very important, where you are immobilized, then you need to stop the you may stop treatment. Generally, it is preferred to stop it about a couple of weeks prior to surgery and again restart after 2 to 4 weeks after surgery once the patient is mobilized. Generally, with regards to female to male, that is testosterone therapy, there is no requirement of stopping any hormone therapy. Now, even in women, male to female who receive transdermal estrogen, but it's something which is difficult one because it's expensive and especially also the humid climate which we have, patches are not that adherent. So those who are on patches, one can stop it for an even shorter period for few days because there the risk of thrombosis is even less. So we generally say about a week's time prior to surgery, and then couple of weeks till the patient is fully mobilized and going on with daily chores. So that's what it's basically the question of immobilization, where there is increased risk of clotting, thrombosis, and pulmonary embolism. But that's more common with the older generation of estrogens, like the conjugated estrogens, less common with the newer estrogens, not with
Okay.
testosterone therapy.
And for how long should one stop estrogens for such surgery?
Yeah, basically for top surgery, it's not really required. For bottom surgery, where there is more immobilization, there it's required, as I said, couple of weeks prior to surgery and 2 to 4 weeks post-operatively. So it's about a month or month and a half where you need to stop at the max.
Okay. Thank you very much, doctor. So, what are the different types of anti-androgens that are used in India, and what are their pros and cons with when compared to one another?
One of the commonest anti-androgens which is used is obviously spironolactone, which is the most commonly used anti-androgens. It's cheap, it's effective, but again we have to monitor because there is chances of increasing potassium levels, which can be risky in certain patients. Secondly, it can cause a lowering of blood pressure. We need to monitor the blood pressures as well. And finally, it doesn't lower the testosterone level per se, because they only mainly act as androgen blockers or testosterone blockers rather than anti-androgens, rather than lowering your testosterone level. So obviously their effect is somewhat less than the leuprolide or the GnRH agonists compared to in terms of testosterone lowering. So that is one we have. Then we have cyproterone, but cyproterone we don't get it in the higher dose as is available in Europe. So generally, it's used as a combination pill. So we generally do not use cyproterone that frequently in this situation for HRT in patients, in persons with male to female gender dysphoria. So we go mainly for spironolactone. We also use the finasteride as well, which is effective in some patients. It has less of chance of this hypotension or hyperkalemia, and but it's again less effective to some extent. It has some role in terms of scalp hair growth. That's an advantage in some persons desiring that. And finally, the probably the most effective, safe, being leuprolide, the monthly or 3 monthly injections, which decrease the testosterone level. But again, they are injectable, which though can be injected by the patient subcutaneously, but they are most importantly very costly, significantly costly. So that is one of the main reasons why a lot of people cannot afford it. That's the main reason.
And is it if a doctor is suggesting Lupride and a patient has financial constraints, can they discuss with the doctor to go for an?
Yeah, definitely. I always, before starting a loop ride, I always discuss with my patients that this is the cost of therapy, whether it is monthly or 3 monthly injections, and whether they will be able to afford it. If we have definitely patients who are unable to afford it, in such a scenario, we give them other options like spironolactone is the first option, which is reasonable and cheap and effective, and with some amount of monitoring which is obviously required. So that is what we give in most of our patients, and also the option of later on adding finasteride or finasteride as an alternative.
Okay, great. And if someone is consulting you, how is the uh, how often do they have to see you in the first year or second year? So,
uh, well, in the first year, generally as per recommendations is about 3 monthly we see, and then in second year it's about 6 months. Every 6 months is something what we generally go for a review, especially with regard to clinical and biochemical monitoring as well.
okay. And we have a question from a user who says, uh, I have completed my vaginoplasty. I'm scared of the side effects of estrogen of hormones. Is it okay for me to not take any hormones after vaginoplasty?
So this is again a very wrong misconception, which is prevalent in a lot of our population. That this that once you are done with the surgery, it's you can stop all medication. So that is something which is not at all desirable, because of one, you are going to be severely symptomatic because you are not having any of your hormones, even your own cis hormone, where previous cis hormones or also the trans hormone. This puts the patient already at risk with regards to your. I was getting a call from your side regarding joint.
Yeah. I messaged the colleague. So yeah, it's right.
So with regards to that, that is an important thing that we need to understand, that these hormones at least have to be continued till the natural age of menopause for trans women, which is about 50 years at least, or even further as well, because that is to protect your bone as well as to some cardioprotective effect of it, because you need some amount of hormones, especially with regards to bone health, as well as with regards to symptoms like hot flushes which can develop, which can be severely symptomatic. And also there can be some amount of cardiovascular benefit, and especially if there is no hormone, there can be some cardiovascular issues as well. So that one form of hormone is required, whether it is male hormone or female hormone. Otherwise, most important risk is fracture risk, which can be very, very high. So the one needs to continue hormones after vaginoplasty, after removal of testes as well, and also in over with regards to trans men, one can continue testosterone for a much longer period of time. Actually, one can continue at a reduced dose for indefinitely, actually, with regards to testosterone.
Thank you, doctor. And how can I know my bone health?
Well, with regards to bone health, one is the most efficient way to know your bone health is to do a bone mineral density by DEXA scan, where you can actually get a picture of your osteoporosis or osteopenia, and that will guide you whether you have any bone health issues. But generally, we do not recommend doing this scan in routine patients. It's basically patients persons who do not, after surgery, just as you mentioned, after getting their gonads removed, whether it is ovary or testes removed, they do not take the hormone therapy, or there has been an interruption in hormone therapy, or there is a very strong family history of fracture, or there is a past history of fracture. In thus these high risk groups only we recommend. Those who are taking regularly after their vaginoplasty and their removal of gonads, and they are maintaining a reasonable level of their hormones, we generally do not require an age BMD, at least till the age normal natural age of menopause, especially in trans women, that is about 50 years or 55 years.
Thank you, doctor. And in case someone, because of the reasons of not taking HRT, has developed osteopenia or osteoporosis, what are their treatment options?
Again, the best treatment option is going back to their hormone replacement therapy, HRT, because till the normal age of menopause, and that has been shown in cis women as well, there's very good data, especially in such population, that giving estrogen in trans women, or giving for that matter testosterone in trans men, actually helps in restoring your bone health and bone mineral density. So that's probably the best way to treat it, unless there is a significant contraindication to taking hormone replacement therapy. Then only we go for anti-osteoporotic therapy. That is not a hormone therapy, but just for osteoporosis per se, which are there, which are oral tablets, injectables also, which are there. But that are these those are not preferred as first line. Generally, the hormone replacement therapy is preferred first line for osteoporosis treatment as well as osteopenia, along with calcium, adequate amount of calcium from the diet as well as vitamin D.
Thank you, doctor. Now, what are the different kinds of estrogens available in India, and what are their safety profiles?
Well, when we, as I was telling you, when we started off some 12, 15 years back, so then the main estrogen which we had at our disposal was basically conjugated estrogen and also to some extent ethinyl estradiol. Now, those estrogens are associated with the increased risk of thrombosis significantly. So now, for last almost 7, 10 years, we have shifted to the natural estrogens, which are generally available nowadays quite frequently. And those estrogens, like estradiol valerate, is one of the preferred estrogen, which are natural estrogens, and they are associated with much lower risk of thrombosis. So we still have the conjugated estrogens. We still have the ethinyl estradiol, but obviously estradiol valerate and are the preferred estrogen. The natural estrogen, that is estradiol valerate, one of them is are the preferred estrogens. We can also go for the injection of estradiol valerate. This is now also available weekly or every 2 weekly, especially that also may be preferred in patients who have a high risk of thrombosis. Again, we also have patches, estrogen patches as well, which are there. But the problem with estrogen patches is that one, they are more expensive, and secondly, in the humid climate which we have in most of the parts of India, then it's the adherence of the patches are an issue, and they fall off quite frequently.
Oh, okay. And the injections you said, are they, because for some time in India they were not visible, they were not available? Are they
Yeah,
back?
yeah, they are now back, because it was available for some time. Then for a period of time it was not available, but now again for quite about a year or so it's again back, and thankfully it's back because
Okay.
it's a better alternative in some patients with regards to use compared, when we are talking about transdermal, then this is an alternative to transdermal estrogen in some of the patients. So estrogen injections are, especially steroid valerate injections are there now from
Yeah.
different brands.
And cost wise also, I think they work the cheapest, right?
Yeah, yeah, yeah. They are cheaper than, definitely much, much cheaper than the transdermal.
Yeah. And if someone really wants to go for transdermal patches, what are the availability in the Indian market and how much do they cost? Do you know?
Well, the transdermal patches are now available, estrogen patches, but they are pretty costly. So there are some brands which are coming out, and hopefully the prices will come down. But it's still very costly, and most of the patients again cannot afford the transdermal patches.
Okay. Thank you, doctor. Uh, Now, coming back to um, progesterone,
If a
what
person
are
can
the
afford, it is preferred. It's safer variety, and especially if it is effective. But for most, again, it's not effective as well because it falls off quite often because of the humid climate as well.
yeah, yeah. And I've also noticed I was using it sometime in India. And especially if you're going to a gym or things like that, it falls off. And then you also think it's so much money that fell off. So I've had some experience, but now I live in Europe and I use it. It's so works so well here. Um, so yeah. So what are the different? Do you recommend people? Do you use progesterone in your with your patients? And what are the different kinds of progesterones that are available in India, and how are they administered and
Well,
safety?
if you look at the guidelines, most of the guidelines still do not recommend. Even if you see the Endocrine Society US guidelines, the WPATH guidelines, we have had our own guidelines. None of them officially recommend use of progesterone routinely. And if you look at even the evidence, the evidence is still not there with regards to whether it is beneficial. It's not established whether it is beneficial or harmful. There is a somewhat of a doubt whether that adding estrogen, adding progesterone to the estrogen, whether that is going to increase the risk of cardiovascular as well as thrombosis risk. That is another issue which is important, which we still do not know. Actually, we do not have long term data in this population. There was this, we extrapolate that from the postmenopausal cis women data, where it was found that there was somewhat higher risk when the combination of estrogen and progesterone was used compared to estrogen alone. So that is not there, but there is some evidence, some small studies showing that there might be some improvement in breast development in a small segment of patients. Again, that is debated whether that's there, because it's not there in all the papers, and also with regards to lowering of testosterone as well. So these are important issues. But as of now, if you see most of the guidelines as they stand now, they do not show, there is no evidence of benefit or harm. So it's no longer, it's not recommended as part of treatment. So I use it very, very scarcely, only when patients insist on that, and after explaining the pros and cons and the risk associated with it. And generally, I have been using it mainly in uh, female to male, where you have persistent, in some who cannot afford GnRH because of persistent periods, and there to give as an alternative to GnRH, which is this injectable progesterones are there, depoprogesterones can decrease till they attain their male hormone levels with injection, testosterone injection, till for decreasing the periods, for stopping the periods in some amount, in some trans female, especially from male to female gender dysphoric subjects, I have used it because they wanted to use it. So, and some have found it beneficial. I haven't used a lot, many. We have oral tablets of progesterone. We have micronized progesterones. We have medroxyprogesterone. We have injections as well, depot injections as well. But we don't prefer using the depot injection because that the dose is much higher and it's there, it's given intramuscularly. We generally go for a much lower doses, and micronized progesterones are preferred. But again, the use of progesterone is very, very limited because it's not as per recommendations in routine patients, and the evidence still is not there whether it is actually beneficial and whether it is harmful also.
Thank you, doctor, for enlightening this, because there's a lot of confusion in the community about progesterone. So I think it clears up a lot of questions for a lot of people. Uh, I have one more question regarding breast development, which is like a lot of people do not uh, understand when, because they're not satisfied sometimes in the very early stage of HRT, and they want to go for a breast development. But should they wait a certain uh, number of years before they go for a breast implant, or uh, what do you think would be a good period to wait before going for any surgical interventions?
Well, if you see, the development starts by about 2 to 3 months, and with hormone replacement therapy HRT, and the full effect comes in for most of the hormone replacement therapy by about 2 to 3 years, which occurs even in normal puberty. That is what I tell most of my patients, that this is what happens in normal puberty. So you have to give it time. You should not rush into things. Like people, a lot of them want to increase the dose of estrogen too quickly. Again, they have to realize it has to be a gradual process. If they rush through it, then the whole architecture becomes different. So you have to understand that has to be made clear. And again, I think waiting for at least 6 months and preferably a year would be better, because then you have given adequate time for the natural development. And I have had number of patients mostly who do not go for breast augmentation surgeries. So we can actually do away with that as well. It can be avoided as well. And of course, if it's not adequate according to what is desired, then one can obviously go for a augmentation surgery. But I would prefer giving at least 6 months to a year's time.
Thank you, doctor. And we have a question from a viewer who says, I am 40 years old. Is it safe for me to start HRTs in my 40s?
Yeah, yeah, definitely. We can, and after obviously proper evaluation of your risk and risk factors, which we always do whenever we start an HRT. And especially, we have had patients in the where they have done their surgery and haven't taken HRT for, means after doing this surgery for 10 years, and their bone health is very bad, and they have sustained fractures. So we have had, and we started even at the 40, 43, 44 also we have started. So after 50, generally transdermal estrogen is what is preferred, but up to 50 one can carry on with the oral tablets of estrogen. But obviously one needs to decrease the doses of estrogen as you age as well.
Okay. Thank you very much, doctor. And what is a post surgery average dose that you recommend for a trans person post op?
Well, again, if you see the advantage is that after the operation, most of the persons will not require any anti-androgens, will not require any GnRH. That's very important. That decreases the cost as well. And also, what we have seen is that we would be publishing this data as well. Is the fact that those requirement after the gonads are removed, the bottom surgery, actually those requirement comes down. So generally, if you look at the estrogen doses, the average doses is between 2 to 4 milligrams with regards to natural estrogen like estradiol valerate. 2 to 4 milligram is the average doses, but it can extend up to 6 milligrams. Some require up to 8, but that's very rare. But generally, for maintenance doses, most of them it's between 2 to 4 milligram, 4 milligrams for 3 to 4 milligrams in most of the patients.
Thank you, doctor. And I
Once you
have a question.
reach a proper level of development, you can again bring the dose back. You can bring down the dose after you have attained the level of development which is desired.
Okay, I didn't know that. I mean, that's pretty nice to know. So once you've had enough breast development and facial, won't they go back to all these developments?
In a significant proportion, you are not cutting down to very low dose, but suppose a patient was taking 4, 5, 6 milligram, you can come back to 4 milligram, or you can decrease by from 4 to 3 milligram. So that is can cut back on the dose.
Okay, that's good. Uh, we have a question from a viewer who says, I want to undergo laser hair removal therapy. Should I start it with HRT or can I do it before HRT?
Well, you can actually do it even before HRT. The advantage of starting with HRT is that you can start HRT simultaneously as well. Because the advantage is that if you have that, then the chances of regrowth, especially if you are already on an anti-androgens along with an HRT, then the hair regrowth will be less as well. So whatever laser or whatever mechanical means you remove the hair, the other areas are still there, and there the hair can come up in the other areas as well. So there, if you are on HRT, then the chances of that coming up decreases, especially if you are on anti-androgens and estrogens together.
Okay. And I've also heard that it requires less sessions of
Yeah,
laser.
obviously that's quite obvious, because moment you have less regrowth, so less sessions will be required.
Yeah. Yeah. Thanks, doctor. And if someone is having excessive hair fall after, uh, I mean, even before HRT, but they have hair fall, what are the treatment options?
So, with regards to hair fall, that's a very difficult issue which we have. We have some topical minoxidil and finasteride creams which are available. How far they are effective, we don't know. Here, there is some role probably I use. First is to get your testosterone levels down adequately. So there is one. This is one situation where I would be preferring leuprolide because that will get your testosterone levels down. You need to be also on an adequate dose of your estrogen. Third is, in some scenarios we have used finasteride because finasteride is helpful for scalp hair growth. There it might be helpful.
Thank you, doctor. And do you think minoxidil or things like that are of any use?
Well, we have used in some subjects have got benefit. Now you even have a combination of minoxidil and finasteride cream as well in India. We have minoxidil cream as well. So it's there in small, in few number of patients have benefited. But it's generally not really for this purpose. Some may benefit, but it's not that routinely they will be benefited.
Thank you, doctor. How many years will it take for me to see a full effects of HRT on me?
Generally, it takes about 2 to 3 years. That's the
Oh,
average timeline.
okay. Thank you, doctor. And in current days, in some countries, it is more and more recommended even for cis women to continue HRT until later and later in life to maintain their bone health and heart health. What do you think should be a age for trans women to stop the HRT?
So if you see the data, we as far as you were asking with regards to the cardiovascular and bone health. The cardiovascular data I was reviewing one of the papers which is a European network meta-analysis of multiple countries, where we have now data in middle term and short term, that is up to 10 years data, where it has been suggested that both estrogen as well as testosterone in trans women and men are safe in terms of cardiovascular risk and in terms of overall health up to 10 years. We don't have data beyond 10 years. That is the international data. Now, with regards to use of estrogen, it mainly comes from the postmenopausal data in women, and it has been seen that after post 10 years of menopause, and especially after the age of 60 years, they may be somewhat harmful in terms of cardiovascular risk. So it's preferable to use below 60 years and up to 10 years. That is about 50 is the normal maximum age of menopause, 45 to 50. So up to 55 to 60 years is the what is generally preferred. So that is the timeline I would say in trans women. I would say it's for 55 years would be the maximum up to stretching up to 60 years. That is what we can use. But obviously, after 50, using transdermal estrogen is preferable because that becomes much safer because your chances of cardiovascular disease increases, and so you need to use safer options. And even after 45 years, we generally tend to decrease the doses of estrogen so that it becomes much safer.
Okay, thank you, doctor. And if someone has any liver issues, like cirrhosis or any liver conditions where some enzymes are high or so, what are the HRT options? I mean, how can they go for HRT?
Well, cirrhosis is one condition where one would prefer avoiding. That is one because it's especially in patients who have some advanced cirrhosis, decompensated cirrhosis. But if liver disease, one can wait till the time the liver enzymes settle down, and especially once the liver enzymes have settled down, then one can start. And if this is started, then probably using a transdermal preparation at a lower dose is safer in such a patient.
Thank you very much, doctor. Now I have one more question, few more questions for you actually. So there is a misconception in the society that cross-gender HRT is dangerous and in general will reduce your lifespan. Lot of transgender people do not undergo transition because of this fear, and they live all their lives stressed and depressed. On a purely medical standpoint, it's known that stressed and depressed people are also known to live shorter lifestyle compared to the content and relaxed people. They develop more comorbidities, cancers, dementia, and etc. on a higher rate. What do you think as a doctor about this? Does HRT really reduce someone's lifespan or general health?
Well, as I have told you just now, I had reviewed one. This is published this year. I had reviewed that publication from European meta-analysis that now we have data up to 10 years suggesting that it's absolutely safe in terms of
You
cardiovascular. It's absolutely safe in terms of your cardiovascular health and also in terms of your overall health risk. Even there is no additional health risk, even
uh,
cardiovascular risk.
we're not able to hear you, doctor. Anna, can you hear Dr. Sanya?
Hello,
Hello?
hello, hello.
Oh yeah, maybe I'm not able to hear you.
Yeah, yeah. I'm able to hear you.
Yeah, yeah, doctor. Sorry, there was some technical issues. Yeah.
Yeah, as I've told you, just mentioned that that paper which was published across in many multi-center paper where it was found to be safe in short term and middle term, up to 10 years, with in terms of overall health as well as cardiovascular health and cancer health, it was found to be safe up to 10 years. Now they have extended that study to look for even longer term beyond 10 years as well. So that is what the data is, that there is no immediate safety concerns. Obviously, you have to have a regular monitoring of treatment as is required for most other people. So that is something we need to understand, provided it is monitored. The issue of health risk comes in because of inappropriate use and overdosing, where the risk actually increases. So one should be under medical supervision. The dosage should be appropriate, overdosing should not be done, and the monitoring should and follow up should be regular. So these are very important things when a person is on HRT. So these are important caveats. If you are following safe practices, then it's reasonably safe.
Thank you, doctor. And you talk the research you're referring to. Is it the energy research from Belgium?
Yeah. The European
Okay.
network meta-analysis, which is there.
Yeah, yeah. We can put the link of it in the for people who are interested to read. All right, we have some questions on the comments. Let me just quickly go through them. How many years will it take to grow my breast to B cup? I think it's very
Well, again, it's very difficult to,
yeah.
it's very much variable. So, that is what I'm saying, that even because the number of receptors uh, in the tissue is variable between person to person. It's genetically determined. So that's why the response to therapy is variable.
Okay. Thank you, doctor. And there's one more question. I don't know much about it, but let me ask you. Lupride is cheap because you have to do it for 3 months. There are some other brands also that are 2 to 3K cheaper. Is there different brands in
Yeah,
Lupride?
yeah. There are several brands available in Lupride, and now you have even cheaper Luprides as well, which are quite reasonable as well. And the 3 monthly Luprides, which I generally prefer, is cheaper than the monthly Lupride. I think that
And
statement is correct to some extent.
okay. And how much does it cost the Lupride treatment? Do you know?
Generally, now probably you have brands costing even as less as 4 5,000 rupees for 3 months.
Oh, that's quite reasonable, I think, for most people. Okay. At which age should I start my HRT? I am 17. I think it is time for me to start MTF HRT. Which age is the right age to go for surgery? Does it harm?
So again, I would say in the Indian population still now, our adult age is 18 years, so we can use GnRH, Lupride, but starting HRT is basically at after attainment of adulthood. In some countries where the age of adulthood is lower, like 17, there one can start, but I would start an HRT generally after attaining adulthood.
Okay. Thank you, Doctor. I think we've answered all the questions. Thank you very much, Doctor, for all your patience. And thank you for our viewers as well for being patient with us. Um, Thank you. Bye, everyone.
Thank you. It was nice interacting. Thank you very much. Thanks a lot.